아니 계란에 증맛 I reposted the PowerPoint, guys. Did you get it? Amy, did you get it?
Yes, I have it.
Does everybody have it now? I don't know for the Montana and Middletown students. I told them to share it. I don't know how to do it on the stupid Zoom, but can you guys share it with all the students, please?
Recording in progress.
Guys, do you see the record button?
Yes,
It's recording, right?
it is.
Thank you. So this PowerPoint I threw together in the last minute because, as usual, you kids, I tell you to send you your Q&A, and then you send it to me this morning, 500 questions this morning, asking me to answer them, which is really annoying. So if you were in front of me, I'd have smacked you on the head, but you weren't. But so I just threw it together. I couldn't put it in, like, I tried to put in some kind of an order, but I couldn't. I don't think it is in great order, but I have a PowerPoint for you. So that's all that matters. All right, guys. So we're doing lower extremity, right? So we're going to do a little bit of an overview of the lower extremity first. And trust me, there are questions on overview kind of things. So these will be helpful for you for the exam. So as you know that these are, darn it, so this is an anterior view of the entire lower limb. Give me 1 second. Okay. So this is a posterior view of the lower limb. This happens to be an anterior view of the lower limb. So when you look at the anterior view of the lower limb, these are the different regions. So you're going to talk about the hip up here. Anytime we're talking about the upper part of the thing, we refer to it as thigh. So if the questions are saying thigh, we're talking about the hip joint. We're asking for movements at the hip joint, and we'll usually say thigh, leg, so make sure you're just paying attention. Leg would be anterior lateral compartment and posterior compartment of leg. Thigh would be anterior compartment, medial compartment, posterior compartment of thigh. And then, of course, you have the gluteal region in the back. And this is the back of the knee. The back of the knee, of course, is called the popliteal fossa. This is the anterior portion of the leg. This is the posterior portion of the leg. This is the dorsum of the foot. This is the plantar surface of the foot. So these are the different surfaces and these are the different compartments. So that's completely different from how the upper limb is arranged. The upper limb, the flexors were in the anterior compartment. The extensors were in the posterior compartment. In the lower limb, you'll find the opposite. The extensors are in the anterior compartment. The flexors in the posterior compartment. Extensor in the anterior compartment of the leg. The flexors are in the posterior compartment of the leg. Okay, so it's exactly opposite, and that's because of rotation of limbs, and you probably studied that in embryology, which you didn't pay attention to for the last exam. Anyway, then we come to this. So the deep fascia for the lower limb is exactly like a stocking, like you're putting a stocking on. So if you put a stocking on and it goes from your foot all the way up to your hip, that is exactly how the deep fascia is. And the deep fascia has different names to it. So in the anterior, in the thigh, the fascia is called fascia lata. Okay, L-A-T-A, because it's whitish looking and it's extremely dense. In the leg, it's called crural fascia. Okay, so here it's called fascia lata. In the leg, it's called crural fascia. Both in the anterior and the posterior aspects of the thigh, it's fascia lata. Both anterior and posterior aspects of the leg, it's called the crural fascia. Then you will find that in the anterior aspect of the thigh, in the thigh, not anterior, but in the thigh, the deep fascia, which is the fascia lata, is going to be extremely thick along the lateral aspect. Along the lateral aspect, it's very, very thick, and it forms this band here called the iliotibial tract or iliotibial band. They are both, they're synonymous. So iliotibial tract or iliotibial band is a common thing that we call. So one of the couple of things that you have to know as far as the iliotibial band is concerned is there are two muscles in the lower extremity. One coming from the anterior compartment, which is called the tensor fascia lata muscle. This guy, he lies in the anterolateral aspect of the thigh. And then the other one is the gluteus maximus, which is in the gluteal region. So the gluteus maximus and the tensor fascia lata are two muscles that actually insert into the iliotibial band. Because these two muscles insert into the iliotibial band, they indirectly have an action on the knee. I have said this so many times in the videos. I've taught a joint. That muscle has to cross the joint. If that muscle doesn't cross the joint, it's not going to have a function on the joint. Tensor fascia lata and gluteus maximus, both of them only cross the hip joint. They do not cross the knee joint. They do not cross the knee joint. So it's a short muscle, tensor fascia lata, that goes and inserts into the iliotibial band. Gluteus maximus, most of the 2/3 of the fibers of gluteus maximus insert into the iliotibial band, and then a portion of the gluteus maximus inserts onto a bony ridge called the gluteal tuberosity. So these two muscles that are mentioned right here on this picture are important for you to know, and these two guys go into the iliotibial band. Okay, so the iliotibial band is also important to know because for practicals, I don't know, in our school, we definitely do in Harlem. We make a big deal about this little tubercle here on the tibia. There's a tubercle called the Gerdy's tubercle. Gerdy's tubercle is found on the lateral condyle of the tibia, and it is an important tiny little tubercle. Darn it. If you kids come on time, things would be so much easier. It disturbs my train of thought so completely. I'm sorry I'm yelling at you. I'm very frustrated today for some reason, and my kids know from my school that I'm constantly yelling at them. Anywho, here we go. So there's a tubercle here called the Gerdy's tubercle on the anterolateral aspect, and look, it mentions it here, Gerdy's tubercle. That's where the iliotibial band inserts. And because these two muscles are inserting into the iliotibial band, and the iliotibial band in turn is crossing the knee joint, and it's going to the tibia to insert on the Gerdy's tubercle, these two guys have a function on the knee joint. They stabilize the knee joint. So during extension, both gluteus maximus and tensor fascia lata help in stabilizing the joint. That's not their main action, by the way. So please don't quote me as if this was their main action. It's not their main action. Gluteus maximus is the most powerful extensor of your hip joint. Tensor fascia lata does medial rotation. It's an abductor. So that's a different muscle. So their actions are separate, but because of their insertion into the iliotibial tract, which in turn crosses the knee joint, they do stabilize the knee joint. but this is about the deep fascia. So whenever you study anatomy, it's good to study it from superficial to deep, skin, superficial fascia, and then you have fat underneath there, and then you have deep fascia. So there's a bunch of veins and nerves. So cutaneous nerves and superficial veins that are important for the lower limb are all found superficial to the fascia lata. Okay, they're superficial to the fascia lata. They're found in the subcutaneous tissue. So that is the overview of the deep fascia. This is again showing you specializations, the same thing. This is the iliotibial tract, and there is the gluteus maximus, and there's the tensor fascia lata inserting into it. And as you guys know, this deep fascia is going to dive in. So if you look at this cross section, the outermost layer you will see is going to be the skin. Underneath the skin, it's going to be superficial fascia, which contains this subcutaneous fat that you see in yellow. And in the subcutaneous fat is where you will find the superficial cutaneous nerves, and you will find also the superficial veins. And we'll talk about the veins because the veins of the lower extremity are extremely important to know. But this guy here is the deep fascia. This deep fascia, which is this purple line that's going all the way around, dives in both in the thigh and in the leg, and it's going to dive in and attach to the bones, okay? So when it dives in like this and attaches to the bone, it forms what is called an intermuscular septum. And these intermuscular septi obviously are coming from the deep fascia. They're going to attach to different margins of the bones. Here it's going to be the femur, and it is going to divide the leg into 3 compartments. So in the thigh, not the leg, in the thigh, you have 3 compartments. You have the anterior compartment, which is extensors, mainly extensors, the medial compartment, which is mainly adductors, okay? And then here is the posterior compartment, which are flexors of the knee, So these are 3 intermuscular septi, okay? You have an anterior intermuscular septum, lateral intermuscular septum, and a posterior intermuscular septum. Just know there are intermuscular septi and that there's 3 of them that are dividing this leg, this thigh, into 3 compartments. This is a cross-section of the leg. In the cross-section of the leg, of course, you're going to have 2 bones. You recognize the tibia as the bigger bone, you recognize the fibula as the smaller bone. Between the tibia and the fibula lies the membrane. This here is called the interosseous membrane. Just like you had an interosseous membrane between the radius and the ulna, you have an interosseous membrane between the tibia and the fibula. This is going to divide the leg into an anterior compartment and a posterior compartment. But there's also intermuscular septi. So if you look at this picture, let me just make this a little bigger. So here again, you have skin, subcutaneous tissue. This is fat. This is where the cutaneous nerves and the cutaneous vessels are. There's the deep fascia. The deep fascia dives in. This deep fascia is going to dive in and it's going to attach to the fibula. Okay, remember that. It's not attaching to the tibia, it's attaching to the fibula. It attaches to the anterior border of the fibula and the posterior border of the fibula. So this is the anterior intermuscular septum. This is the posterior intermuscular septum. So you have 2 intermuscular septi, and then you have an interosseous membrane. Now you divide this entire leg again into 3 compartments. These 3 compartments happen to be anterior compartment, a gigantic posterior compartment, and a small lateral compartment. So in the thigh, you have a medial compartment. In the leg, you have a lateral compartment. In both cases, you have anterior and posterior compartments. So those are the intermuscular septi, and that is what happens with the intermuscular septi. Okay. I know I'm going fast because I have to cover so much. Okay.
Dr. Rich, sorry to interrupt. Just to clarify, you said the medial side is adduction, right?
Where?
On the last slide.
No, but where? Up, leg, thigh?
Oh,
thigh or leg?
we were talking about the intermuscular septa, so the leg.
There is no medial compartment in the leg. There's only lateral compartment in the leg. In the thigh, there's a medial compartment. The medial compartment of the thigh is all adductors.
Perfect. Thank you.
Yep. Okay. So then you have some specializations of deep fascia, just like we had specializations in the hand with the flexor retinaculum and the extensor retinaculum. Here you have on the anterior compartment of the leg, you have a superior extensor retinaculum. Then on the dorsum of the foot, you have another thickening of the crural fascia. Crural fascia is what it's called in the leg, don't forget. And it is thickened to form what is called the inferior extensor retinaculum. So this is the inferior extensor retinaculum. It's a Y-shaped band, and this is a superior extensor retinaculum that's just a band. But, on the medial aspect of the between the posterior compartment of the leg and the foot, while it's transitioning right here, is a very important retinaculum. This retinaculum is called the flexor retinaculum, just like we call this the flexor retinaculum. So this flexor retinaculum encloses a tunnel. And in the hand, it was called the carpal tunnel. In the foot, it's called the tarsal tunnel. Well, it's actually a transition between the leg into the foot. So in the tarsal tunnel, of course, you have structures. What are the structures, guys? What's the mnemonic?
Tom, Dick, and Harry.
Correct. Thank you for the enthusiasm. Tom, Dick, and Harry. So tibialis posterior being the most anterior structure. So questions will ask you like, what is the most anterior? Don't forget, anterior would be tibialis posterior. Right behind it is flexor digitorum longus. Tom, Dick, AN, right? Artery, tibial nerve. Artery is posterior tibial artery. The nerve is just tibial nerve. It's not posterior tibial nerve. So the artery nerve, and then you have flexor hallucis longus that lie underneath the flexor retinaculum. And this is an important area. Just like you had carpal tunnel syndrome, you can get what is called tarsal tunnel syndrome, where these tendons can get compressed. There could be friction. They could put pressure on the nerve, and you can get tingling and numbness along the distribution of the tibial nerve, which would be further. So if the nerve is getting compressed here, distal to the site of injury, you will have tingling and numbness. So this is the tarsal tunnel. The order in which they lie is important for you to know, and you guys know already. It's Tom, Dick, and Harry. Hey, in this picture, this is important to know. This is the dorsalis pedis artery. This dorsalis pedis artery is one of the peripheral pulses you are expected to feel. This one and posterior tibial pulse, right? So those two are peripheral pulses that you feel. So this pulse, look at its location, know its location. Dorsalis pedis artery, which is the continuation of the anterior tibial artery from the anterior compartment of the leg, comes into the dorsum of the foot. He lies lateral to this tendon here called extensor hallucis longus tendon. This is extensor digitorum longus. This goes to the lateral four toes. This dorsalis pedis artery is found on the bones. These are the tarsal bones that you see here. It lies on the bones between these two tendons. So often they'll ask you for surface landmarks of where to feel the dorsalis pedis artery. You will feel it lateral to extensor hallucis longus. This is lateral between EHL and extensor digitorum longus. So that's where you feel the dorsalis pedis pulse. Okay. And then the deep fascia, we're talking about deep fascia. So the deep fascia on the plantar aspect of the foot is also a very important thing. It's called plantar aponeurosis. Plantar aponeurosis is exactly like the palmar aponeurosis. It's a triangular band. And here it is, it's a triangular band. It's going to divide into these fascicles as it goes towards the toes, and then it goes all the way down. It kind of merges with a ton of deep fascia here. That's about what you want to know about the plantar aponeurosis. It also throws off two intermuscular septi, one from this edge and one from this edge that are diving deep in, and those are called intermuscular septi, and they make compartments in the foot, a medial compartment, a lateral compartment, and a central compartment. Plantar fasciitis is a common inflammation that happens with plantar fascia. You're not doing pathology right now, right? When you do, I guess are you doing general path now? Speak, people.
No.
No.
No. In general pathology, you will learn
No.
there's this condition called enthesopathy. But anyway, so plantar fasciitis is when this fascia gets inflamed because there's a little bone growth here that pushes on the plantar fascia. Runners get plantar fasciitis, and it's very important to know that plantar fascia can get inflamed because there's a little osteophyte that grows on the bottom of the calcaneus, and then it puts pressure on this plantar aponeurosis and causes shooting pain down this entire extension of it, okay? That's about all you have to know for it now. Veins of the lower extremity. If you have questions, speak, because I'm speaking fast. Just interrupt me. Okay, so superficial veins. The superficial venous system of the lower extremity is extremely important clinically. The superficial venous system of the lower extremity is where we get deep vein thrombosis, not deep vein, we have varicose veins, we can get venous ulcers. Those are all happening with superficial venous system. Generally, the way this works is it begins from this venous arch here. If you look at your foot, on the dorsum of your foot, close to your knuckles, there is a dorsal venous arch. This dorsal venous arch, just like you had one right here, there's one down here. This dorsal venous arch on the medial side of the dorsal venous arch will ascend up, and it will be called the great saphenous vein. This great saphenous vein goes anterior to the medial malleolus. And then it goes up, and it's traveling along with the companion. The companion that travels with this great saphenous vein is a nerve called saphenous nerve. Where the heck is the saphenous nerve coming from, people?
The femoral
Saphenous.
artery?
What? Saphenous nerve.
Femoral vein? No.
Femoral what?
Femoral nerve?
Femoral nerve. It's not coming from an artery. It's not coming from a vein. The nerve that accompanies the great saphenous vein is called the saphenous nerve. That saphenous nerve is a branch of the femoral nerve that we see in the femoral triangle. Remember the saphenous nerve. He's going to travel not up here, not where I'm pointing to. He's given off in the adductor canal. So somewhere along this point where I'm pointing to, the saphenous nerve is given off, and then he will travel with the great saphenous vein. He'll come down all the way down, and he supplies cutaneous sensation to the medial aspect of the leg. Don't forget, he ain't doing anything up in the thigh. Nothing. He's not supplying anything. He's a cutaneous nerve. He's coming from the femoral nerve, which is a nerve from the anterior thigh. And he's given off in the lower mid portion of the thigh. He travels with the great saphenous vein, and then he supplies cutaneous sensation to the medial aspect of the leg, comes all the way down and supplies sensation up to the middle of the medial arch of the foot. I will show you a picture. Coming back to the great saphenous vein, which is the longest vein in the body, it's a superficial vein. It is arising from the medial side of the dorsal venous arch, goes anterior to the medial malleolus, accompanied by the saphenous nerve. He goes all the way up. He goes into the femoral triangle, and then there's an opening there called the saphenous opening. He pierces and goes and drains into the femoral vein. Femoral vein is a deep vein. So there's a superficial venous system and there's a deep venous system. The two most important veins of the superficial venous system are the great saphenous vein that lies on the medial aspect, and then the small saphenous vein. The small saphenous vein is the continuation of the dorsal venous arch on the lateral side. So this is the lateral side of the foot. This is a posterior view that you're seeing. So he arises on the lateral side of the dorsal venous arch. This guy goes posterior to the lateral malleolus. Great saphenous then went anterior. Small saphenous goes posterior to the lateral malleolus. And then he's kind of in the dead center, ascends up, and he too has a traveling buddy. His buddy is called the sural nerve. So he travels with the sural nerve, he comes up, and he will drain into this deep vein here called the popliteal vein. People, you know that the femoral vein becomes the popliteal vein, right? So it's really the same vein. It's just that you're tracing it in the back here. So the small saphenous vein drains into the popliteal vein. Now, I told you that it's accompanied by a nerve called the sural nerve. This sural nerve is important for you to know. So often what will happen is often what will happen is that they will ask questions like, oh, they took a small saphenous vein, they needed a venous graft, so they took a piece of the small saphenous vein, and 2 days later, the patient is complaining of tingling and numbness along the posterior aspect of the leg and also along the lateral border of the foot. That's because the sural nerve was cut, which is very closely running along with it. Same kind of question with GSV. Great saphenous vein. Great saphenous vein we use all the time for cardiac bypass. It's the most commonly used one. They use radial arteries, they use different things now, but great saphenous vein is one of those veins because it's so long. If there is a big blockage and I have to bypass a huge blockage in the heart, this is a good vein for me to use. So great saphenous vein is the most commonly used vessel to bypass, do a coronary artery bypass. The question can say, hey, we took the great saphenous vein, after which patient has tingling and numbness along the medial aspect of the leg or medial border of the foot, like it goes to the middle of the medial border of the foot. And what nerve was affected? That would be saphenous nerve. Or it could say, sometimes questions will say, hey, when you sever the femoral nerve, and you're thinking, when you think about a femoral nerve, you're thinking that it's supplying all the muscles of the anterior compartment of the thigh. You forget that that femoral nerve is supplying cutaneous sensation to a distal portion of your limb, which is the medial aspect of the leg. Don't forget about the saphenous nerve, which is a cutaneous nerve that is supplying the medial aspect of the leg, okay? Yeah, it's the same thing here, showing you the two veins and what they drain into. Clinical correlates you guys can look up. Varicose veins are extremely common. Venous ulcers, very, very common. These are the worst things, they never heal. You have to constantly debride them. You have to clean them. So venous ulcers are a problem. So you should know about venous stasis, varicose veins, and venous ulcers. These is all just clinical stuff. Lymphatic drainage. Somebody wanted to know about the lymphatic drainage. So here we go with the lymphatic drainage. This is how the lymphatic drainage works. How do we do it? Okay, so there's inguinal lymph nodes, okay? There are two sets of inguinal lymph nodes. Inguinal lymph nodes meaning that these lymph nodes are found in this region here, which is the inguinal region, which is where there's an inguinal canal. You'll learn about this when you do abdomen. This is where inguinal hernias are common. But anyway, this portion here is called the inguinal region. So there is a ligament here called the inguinal ligament. You guys know the inguinal ligament because this forms the boundary for what, people?
The femoral triangle.
Correct. It is the superior boundary for the femoral triangle. The inguinal ligament is running from the anterior superior iliac spine to the pubic tubercle, and all along the inguinal ligament, there's a bunch of lymph nodes that lie here. These are called the horizontal group of lymph nodes, okay? Because they run horizontally, kind of. Then, this is the great saphenous vein. Let's make this picture bigger. So, so these are the superficial inguinal lymph nodes. Then, horizontal group of superficial inguinal lymph nodes. Then you have vertical group. This is a vertical group of lymph nodes. These vertical group of lymph nodes run along the terminal end of the great saphenous vein. So this is the great saphenous vein. It's going to end into the femoral vein. It's going to drain into the femoral vein. So as it's going to drain into the femoral vein, along its distal end, along its proximal end, this is where the lymph nodes are found. These lymph nodes are called vertical group of lymph nodes. Then there is a set of lymph nodes called deep lymph nodes. Deep lymph nodes are found along the femoral vein, which is deeper than this. This is fascia lata. These lymph nodes are found superficial to the fascia lata. This is the fascia lata. So these are horizontal group. This is a vertical group. And then there's a deep group that's found along the deep aspect of the femoral vein. I'll show you a picture right here. Here is the femoral vein. This is the great saphenous vein draining into the femoral. And so along the femoral vein, there are deeper group of lymph nodes. All you have to know is very, very simple for lymphatic drainage for now, for lower extremity. The lateral side of your foot, right? Lateral border of your foot and the calf, this whole calf here, is all of that will drain into the popliteal lymph nodes. They travel alongside the small saphenous vein and they will ultimately drain into group of lymph nodes that you see here called popliteal lymph nodes. So these little guys are popliteal lymph nodes. This here is the pop fossa. That's the popliteal vein. That's the popliteal artery found deep in the pop fossa. If I asked you what is the deepest structure in the pop fossa, you would say?
Popliteal artery.
Without a doubt, popliteal artery is the deepest structure in the pop fossa. When you have femoral condylar fractures, doesn't matter, any kind of femoral condylar fractures, this artery is in danger. So condylar fractures of the femur put the femoral artery in danger because it's biting the bone. It's like literally on the bone. Femoral vein is a little bit more superficial to it. So this is, popliteal vein. Did I say femoral artery? I meant popliteal artery. We're in the pop fossa. Popliteal artery is the deepest artery in the pop fossa. This is the one that always gets hurt when there's femoral condyles fractures. This is the one that's at risk. Here's the popliteal vein. Along the popliteal vein, you have lymph nodes. These are called popliteal lymph nodes. So lateral side of the foot, any infection on the little pinky, along the lateral border, any infection along the calf, right? Anything along the superficial aspects of the calf. All of that, these lymphatics that you see in green, follow the small saphenous vein, and then all these lymphatics drain into this set of lymph nodes here called popliteal lymph nodes. If you see lateral border of the foot infection and it's asking you for what lymph nodes, close your eyes and say popliteal lymph nodes. If it's asking for back of the leg, any infections along the back of the leg, popliteal lymph nodes, okay? And then the other lymphatics, so let's just finish the other lymphatics. So, So you see how this
Sorry to interrupt.
Yes.
But did you say that the femoral artery would be not the femoral, the popliteal artery would be most at risk if you had a femoral fracture?
If you have a femoral condylar fracture, the most commonly injured or the one that is at risk happens to be the popliteal artery.
Okay, thank you.
This is the popliteal artery. The femoral artery is in the anterior compartment. It's lying amidst muscles in a canal called adductor canal. So it doesn't get injured as often because it's not close to the bone. This guy, the popliteal artery, is on top of the femur, okay, in the back. So it is the one that gets affected in femoral condylar fractures. Yeah?
Yep, thank you.
This here is the great saphenous vein, so we're talking about lymphatic drainage. So any other infections, people, medial dorsum of the foot, medial aspect of the foot, anterior leg, all of anterior leg, all of anterior thigh, posterior thigh, gluteal region, the whole thigh, the entire thigh, all of those infections will go to the vertical group of lymph nodes right here. So all of thigh, anterior, posterior, medial, you see how all of the lymphatics are draining, coming in. All of those things, these guys will get infected. These guys will enlarge. Only the lateral side of the foot and the back of the leg, all of this goes to the pop fossa, to the popliteal lymph nodes. All of this here, dorsum, medial side, anterior leg, anterior, posterior, and gluteal region of the thigh, all of those lymphatics ultimately tend to come and go into the vertical lymph nodes. The horizontal lymph nodes that we talked about, they will drain the lower portion of the abdomen. And there's more specific things that you'll learn later on. But if you know this much about lymphatic drainage, you're good. Do you have any questions?
Yes, sorry.
Yeah.
Yes.
Sorry. Would you say that the popliteal artery is the deepest in the pop fossa and not?
Yes,
and how about-
absolutely.
And where would the popliteus muscle lie?
So here is the pop fossa. So this would be the medial aspect. So this is the medial aspect. The femoral artery is going to come through here, become the popliteal artery. The popliteus muscle is down here in the pop fossa because the popliteus muscle arises on the lateral condyle of the femur as a tendon, comes around, it's inside the knee joint capsule, and it attaches here. So this is where the popliteus muscle is. When we talk about muscles, when we talk about fractures of the bone, we generally are concerned about two things. We're concerned about nerves and arteries. We're not that concerned about the muscles because there's more than one muscle which can do the same function. There's compensation that can happen. So the popliteus muscle is of no relevance for us as far as condylar fractures are concerned, except at its origin, popliteus tendon could get cut if there was a severe fracture here, and the tendon might get severed. But when we are talking about injuries, we generally are more concerned about arteries and nerves. Arteries because arteries are supplying oxygen and you don't want muscles to become ischemic, and nerves because nerves cause nerve injury and the muscle is not able to function.
Okay, but if there was a question about the floor of the pop fossa, would it be in the
The
lecture
floor of the
itself?
pop fossa will be formed by the following: femoral popliteal surface of the femur, which is this surface of the femur here. This is triangular surface of the femur. And this soleal line here, which has popliteus muscle. So at the distal portion of the pop fossa, the floor is formed by the popliteus. If they're asking you of a muscle, there's only one muscle that forms the floor, popliteus.
Thank you.
Esther,
Hi, Dr. Rich.
hey girl.
Is it possible? So the dorsum, anterior of leg, and what else drains into the vertical?
Almost the rest of the entire leg, right? Except for the back of the leg and the lateral side. If you just remember it that way, that would make it easy.
Okay.
Except for the lateral border of the foot and the back, the calf, those two go into the popliteal lymph nodes. The rest of the leg goes into the vertical groups of lymph nodes. From there, it'll go to the deep lymph nodes. From there, it passes on because the lymphatics go further and further. But which lymph nodes get affected first would be the vertical groups of lymph nodes.
Oh, okay, perfect. Thank you so much.
Yep.
Hi, sorry, Dr. Rich. I have one more question.
No, you're not sorry. Stop it.
Sorry.
Go ahead.
You were saying that the popliteal artery is like at risk for a condylar femoral fracture, but for the femur neck fractures, that's the medial circumflex artery, right? And
That's
like what
correct.
causes
That
the
is
necrosis.
correct.
Okay.
That is correct. That is correct. And we're going to talk about that in a second. Okay, so these are the major nerves of the lower extremity that we want to know. This is a good, nice little thing that tells you all you need to know about all the different nerves and all the different compartments, right? Femoral nerve supplies anterior compartment muscles, and it is going to also supply saphenous nerve, which is going to be cutaneous to the medial aspect of the leg and the medial border of the foot, like mid portion of the medial border of the foot. That's how far the saphenous nerve goes. And femoral nerve is supplying all of the muscles in the anterior compartment. There's a couple of muscles that have dual innervation that you should know. One of them is pectineus. Pectineus may have dual innervation from femoral nerve and from obturator nerve. Then the obturator nerve is the nerve of the medial compartment. Obturator nerve and obturator arteries supply the medial compartment of the thigh, which is the adductor muscles. Exception to the rule in the adductor compartment muscles is adductor magnus. Adductor magnus has two nerves that can innervate it because it has two origins. It has two portions to it. Do you guys know that the adductor magnus has an adductor portion and a hamstring portion? The adductor portion comes from the pubic bone. That means that's where its origin is. I'm talking about the magnus, which is the deepest muscle. And it also has a small portion that arises on the ischial tuberosity. Anytime a damn muscle arises on the ischial tuberosity, it's called a hamstring. So that's called the hamstring portion. So hamstring portion of the adductor magnus. Now, adductor magnus can get two nerves innervating it. One is obturator nerve, and the other nerve is going to be the tibial component of the sciatic nerve. So that is an exception to the rule. Note that down, know it. Pectineus has dual innervation, adductor magnus has dual innervation. Sciatic nerve. So sciatic nerve supplies the posterior thigh. Posterior thigh. And in the posterior thigh, it hasn't separated normally. It doesn't separate into its two components, which is tibial and common fibular components. it is going to supply the hamstrings. The exception to the rule is what, guys? For the hamstrings, what is the exception to the rule for nerve supply? All the hamstrings are supplied by the tibial component of the sciatic nerve, with the exception of?
Short head.
Thank you, short head of biceps. Short head of biceps is going to be supplied by the common fibular component of the sciatic nerve. The sciatic nerve.
Isn't the short head not hamstring because it's short and it's not from the
No, it is
physiography?
not. It's not considered a hamstring, but still, it is going to join a hamstring. It's going to join the long head of biceps. So by association, it could be a hamstring. This is an eternal conversation that people have. Not important. Anatomists have nothing else to do but fight about stupid things. There you go.
Thank you.
Okay. So the tibial nerve, so the sciatic nerve will come into the pop fossa. It's going to divide into the tibial component and the common fibular component. The tibial component is much larger, so you will see that here. I don't know why I'm not pointing to this while I'm showing this to you. So here is the posterior view. The sciatic nerve is lying. So the sciatic nerve comes out of the greater sciatic foramen, right? When it comes out of the greater sciatic foramen, what is its relationship to the piriformis muscle here, guys?
It
Doesn't
runs
it go
up
on-
under.
It goes what?
Wait, can you repeat your question one more time?
What is the course of the sciatic nerve in the gluteal region? So it's coming out of the greater sciatic foramen. How is it related to the piriformis muscle?
It goes underneath the piriformis muscle.
We call it inferior, right? We call it inferior, Daphne. We're going to call it inferior. It goes inferior to the piriformis. Sometimes it'll divide into two, and portion of it will go through the piriformis. That's when you get the piriformis syndrome, right? Sometimes it can come superior to the piriformis. There's variations. But normal anatomy, this dude is supposed to rise along the inferior border of the piriformis. He runs inferior to it, and then he's lying between the greater trochanter and the ischial tuberosity. That's why we don't want to give an injection, intragluteal injection in this neighborhood here. So they'll always ask you, where is the best place to give an intragluteal injection, which is an intramuscular injection. It's usually in the upper outer quadrant here, so you don't affect any nerves. And remember that the piriformis comes out of the greater sciatic foramen, and along the superior border lies the superior gluteal nerve. Along the inferior border, there's inferior gluteal nerve. There's big, gigantic sciatic nerve. There's this nerve here that you see called the posterior femoral cutaneous nerve, a bunch of nerves. So our best bet to give an intramuscular injection is the upper outer quadrant. So here's the sciatic nerve. He comes through here in the pop fossa. He's going to divide. He doesn't divide this high up. He divides further down here into the common fibular component and tibial component. We all know this is the common fibular component. This is an anterior view. The common fibular component is so important because it's going around the neck of the fibula. Fibula neck fractures are common. If the fibular neck is fractured, then this common fibular nerve is going to be affected. If the common fibular nerve is affected, both the divisions, it hasn't divided yet into superficial and deep fibular, so the whole common fibular nerve loses its function if it's severed, which means anterior compartment muscles don't work, lateral compartment muscles don't work. If the anterior compartment muscles don't work, anterior compartment of the leg muscles do dorsiflexion. And tibialis anterior will also do inversion. So there'll be weakness inversion. Dorsiflexion will be kind of lost, really completely lost, because there's nothing else there to do dorsiflexion. Severin, I see you. Give me 1 second. Superficial fibular nerve is going through the lateral compartment, and he's supplying the everters, which is fibularis longus and brevis. So you can't evert, right? So eversion is lost. Dorsiflexion is lost. People, when muscle groups are completely paralyzed, the opposite muscles will take over. Opposite muscles will take over. So don't forget, if sometimes the questions will ask you, what position will you find the foot in? Or it'll say, which means in this particular case, let's take this case, for example, if the deep fibular nerve is affected, anterior compartment muscles are not working, so dorsiflexors are not functioning, so your foot will be plantar flexed. At the same time, the superficial fibular nerve is also damaged. If the superficial fibular nerve is damaged, the lateral compartment muscles are affected, and the lateral compartment muscles are powerful everters. So your foot will be inverted. remember, these kinds of things are important for you to know. Let's go with Severin first. What's up, Severin?
Two quick questions. So regarding the last thing you said, so if the group of muscles, they all are paralyzed, would that be the same if the nerve that innervate them is paralyzed as well? The effect will be the same, right?
Correct.
Okay. So the
But
next
all
question.
of them, but you're talking about, so don't forget, Severin. So if the deep fibular nerve supplies a bunch of muscles, it is supplying tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius. So if the deep fibular nerve is cut up here, all those muscles will lose function. But if a muscle is cut, only that muscle's function will be lost. Correct?
Yeah, that's clear.
Okay.
Yeah.
Okay.
Now, just a second clarification. So if the sciatic nerve divide or split just above the popliteal fossa, is there a true popliteal nerve?
Is there a popliteal nerve?
Yes.
There is no popliteal nerve.
Okay,
The sciatic nerve divides into two, tibial and common fibular. That's it.
Thank you. Yeah.
Yep. Mrs. Abraham.
Good day, Dr. Rich. So
Good day, girl.
thank you. If we have a fibular neck fracture, will we also lose the sural-cutaneous nerve? So sensation on the lateral aspect?
Speak. So if you have which fibular nerve? Common fibular nerve?
So the fibular neck fracture, if it knocks out the common fibular nerve, won't you also lose your lateral sural-cutaneous sensation along the lateral aspect of the leg and foot?
Well, that's a difficult thing to say. No, not fully, because the common fibular nerve gives a communicating branch to the medial sural nerve, and then the sural nerve is formed. But it's only a communicating branch, so you don't fully lose all of the sensation. You might have a little loss of sensation, which you can't really pinpoint on. But the sural nerve will still continue, the medial sural nerve will still continue down, and it will continue to supply cutaneous sensation.
Okay, so like for example, if a question was like saying numbness and tingling and things like that, then we wouldn't say it was sural. We would still stick with the common fibular nerve being
It
damaged.
depends on where the tingling and numbness is, right?
The lateral aspect of the fibula.
Along the lateral side of the fibula, it would be the sural. There's a nerve called lateral sural nerve. So if you look at the cutaneous nerves, you will see that there is a lateral sural nerve that supplies the lateral aspect, not the fibula. You were talking about cutaneous sensation, so it should be along the skin, along the lateral aspect of the calf, you mean, right? Not the fibula. If the nerves that are going around the fibula is the common fibular nerve. That's the one that's going around the neck of the fibula. The cutaneous nerves are very superficial. They're underneath the skin.
Oh, okay. So that the common fibula doesn't give a branch to the cutaneous. Is that correct?
It does give a branch to the cutaneous, and that stuff is happening in the back of the leg. And yes, it does, but that's not going to completely make you lose cutaneous sensation to the lateral aspect of the leg.
Okay. Merci.
No. And you know what? I see what's going on. And what is your first name?
Mine?
Yes.
Masai.
Masai. Girl, here's the thing. Don't read into questions way too much and go crazy. You see how you got confused between a cutaneous sensation and something that's going around the neck of the fibula? What's going around the neck of the fibula is a big nerve called the common fibular nerve. That cutaneous sensation stuff is happening underneath the skin in the superficial fascia. Yes, a small portion of the common fibular nerve gives a little branch called the communicating branch. If the common fibular nerve is cut, the communicating branch could be cut, then you might have a little tingling and numbness, but that's way too much that none of us even know about.
Okay, so when we approach questions or for this upcoming exam, when I'm just trying to understand.
The question should clearly say cutaneous innervation. The question would say tingling. If the question is saying tingling and numbness, it's cutaneous innervation.
Okay.
Tingling and numbness often happens only with cutaneous sensations. With these other nerves, which are motor and sensory, like common fibular nerve, superficial fibular nerve does supply cutaneous sensation to the dorsum of the foot. So if the common fibular nerve is cut here, you will have tingling and numbness on the dorsum of the foot because the superficial fibular nerve, after it supplies the lateral compartment muscles, it becomes cutaneous to the dorsum of the foot.
Okay.
So you have to know every nerve and what happens to that nerve. Is it carrying motor fibers and cutaneous fibers? Because what you asked me earlier is a very cutaneous one. Yes, Tyler.
Hi, I just had a question. I was doing the sketchy like lower limb innervations, and
I
it
don't
was
know what
talking
the
about
heck that is, bro.
oh,
But
it's like a Toro app something, but it was talking
Whatever.
about bladder and bowel incontinence in relation to the tibial nerve. Do we need to know that, or is that beyond the
what?
scope of
What?
the
What?
I don't know.
What?
I didn't know
What
if that
the
was
heck,
like
huh?
beyond the scope of the exam.
Absolutely beyond the scope of the exam.
Okay, thank you.
Tibial nerve is a component of the sciatic nerve. Sciatic nerve is formed by L2, L3, L4, L5, S1, S2, S3. So if it is L4, L5, S1, S2, S3 disc issue or a spinal cord issue, then you will have stuff like that. Esther. Yeah, it's beyond the
So
scope.
hi, I was just wondering, so you were saying that if the person has a fibular fracture at the condyle, right? Then they would have weak inversion.
Wait, what? Say that again.
Oh, sorry, fibular neck fracture.
Okay, good. Yeah.
And so they would have weak inversion, lose dorsiflexion, and they can't evert. But then we said we're going to find the foot inverted.
So because the everters are lost, right? The powerful
Yes.
everters are not working. So tibialis posterior, which is an inverter, will invert the foot.
Okay, and it will just be slightly, I guess, or weakly inverted or
Oh,
strongly.
no, it still is because so here's the other thing you have to
Ah.
know about these kinds of musculoskeletal questions. These everters are extremely powerful. So you have lost all of eversion now. You've lost fibularis tertius, which is a weak inverter. You've lost fibularis longus. You've lost fibularis brevis. All of eversion is completely lost. So even that one tibialis anterior that is a pretty good inverter, tibialis anterior and tibialis posterior share the common action of inversion. Tibialis anterior is going to be lost now, but tibialis posterior will invert the foot.
Okay, perfect. Okay, thanks. That makes sense.
Yeah. Okay. So common fibular nerve fractures, please know what will happen, what muscles it supplies in the anterior compartment and the superficial. Now, I was talking about the superficial fibular nerve, and I said the superficial fibular nerve is very similar to the musculocutaneous nerve. It is going to supply muscles in the lateral compartment. After it supplies the muscles in the lateral compartment, it is going to become cutaneous to dorsum of the foot. And I will continue with that in a second. This is important to know, okay? Cutaneous innervation of the leg in the front and in the back. Please know this. Don't worry about these guys, these little genitofemoral branches, the ilioinguinal. We haven't done these guys yet because these are from the lumbar plexus and they lie in the posterior abdominal wall. But these, I mean, this is where they're coming from. So these little guys you don't have to know, but you want to know. Look at the amount of stuff that the femoral nerve is supplying. Femoral nerve is also coming from the lumbar plexus. There's a nerve called lateral femoral cutaneous. You dissected it. That guy is going to supply the lateral aspect of the thigh. Don't forget the obturator nerve. Obturator nerve is supplying a little portion of the medial side of the upper thigh, a small portion. So look at this picture, have an idea of what nerves and how much of cutaneous sensation they supply. Look at the saphenous nerve. The saphenous nerve is a branch of the femoral nerve. He supplies a big portion of the medial aspect of the leg, and he comes down and supplies a little bit of the medial border of the foot. So take a look at this. There are questions on cutaneous sensation you should know. So this is lateral sural cutaneous, this thing here. So sometimes, right, there's such a confusion between this is lateral sural cutaneous is a branch from the common fibular. He supplies a large portion here, okay? This is the sural nerve. Sural nerve is going to supply some portion here, back of the leg. Then he is cutaneous to the lateral side of the foot. So overall, the big ones, make sure you know the cutaneous sensations for the gluteal region, for the thighs. So take a look at this picture and have an overview of it, which then brings me to this foot question here. Here is the superficial fibular nerve. He supplied the lateral compartment muscles. He's going to pierce the deep fascia, makes a hole in the deep fascia, comes out of the deep fascia, and he's going to supply the dorsum of the foot. This is the superficial fibular nerve, just like the musculocutaneous became the lateral cutaneous nerve of the forearm. He's going to come down. He's supplying a large portion of the dorsum of the foot, with the exception, which is an exam question, is this first web space. The first web space here in yellow is supplied by the deep fibular nerve. And this becomes important because if I'm anesthetizing this portion of the big toe, the lateral aspect of the big toe, or the medial aspect of the second toe, I have to anesthetize the deep fibular nerve. Deep fibular nerve, which supplied the anterior compartment. He's deep in there, but then when he comes to this first web space, he becomes superficial. He comes out and he'll divide into two branches and supply the either side of the adjacent toes. So this is done by deep fibular. This is important to know. This is sural nerve. This guy in the back that we saw here, this sural nerve that was traveling with the small saphenous vein right there, those two travel together. He supplies a small portion along here, back of the leg, and then he goes and supplies the lateral side of the foot. So this guy, he's going to supply the lateral side of the foot. Where they call it dorsal lateral cutaneous nerve of the foot, it's really the continuation of the sural nerve, okay? This is all superficial fibular. This is deep fibular. This picture is important. Know it, okay? Dermatomes, look at the dermatomes. I don't have time to go to them. Just have an overview. Like in the front, it's all L1, L2, L3. They go in order, kind of. In the back, it's S2, S3, S1, S2, S3. It ascends up this way. So try and make something up. This is all just movements of the lower extremity. This is flexion, extension of the hip, flexion of the knee. And you guys know inversion and eversion are two movements that are possible at the subtalar joint. Dorsiflexion and plantar flexion are these. At the ankle joint, that's where these movements happen, at the ankle joint. So take a look at those pictures. These are all clinical correlates. This is patellar reflex. Please know what nerve are you testing when you hit the patellar ligament, guys?
Femoral nerve.
Femoral nerve. So know the roots for the femoral nerve, and you should know the roots for the femoral nerve, okay? So it's L2, L3, L4. That's the patellar tendon that you're tapping. You're not tapping the quadriceps tendon. Quadriceps tendon is the tendon up here. Once the quadriceps tendon encloses the patella that you see here, it becomes the patellar ligament. It's called a ligament even though it's a tendon, and it inserts on the tibial tuberosity here. So we hit that patellar ligament here. You'll see the contraction of the quads, and that is how you test L2, L3, L4. Plantar reflex. So these reflexes are important for you to know. Plantar reflex, you should know, is going to test L4, L5, S1, S2. You guys know how to do a plantar reflex, right? You guys have done it. This is how you do it. This is what normally should happen. Your toes should flex. If they actually expand outwards, it's called a positive. It's called a Babinski sign, which means that it is abnormal. So that is the normal plantar reflex. Here is the femoral triangle. This is the anterior compartment muscles. What do you want to know about the anterior compartment muscles? First of all, you have the quads here. This is the rectus femoris. Rectus femoris is different from vastus lateralis and vastus medialis. This is lateralis, this is medialis. Rectus femoris crosses two joints. It crosses the hip joint and the knee joint. Vastus medialis and vastus lateralis, even though they're in the anterior compartment, these guys are arising in the back, people. They're arising in the back of the femur on a thing called linea aspera. They arise from there and they wrap around the entire femur. And so these guys are arising on the femur, and they're not crossing the hip joint. This guy, he's arising on the anterior inferior iliac spine. He's got two heads, the rectus femoris. One arising on the anterior inferior iliac spine, the other head arises on the acetabulum. So he crosses the hip joint. So he has an action on the hip joint. So they often ask about the rectus femoris crossing the hip joint and what is its action. This is tensa fascia lata. He is going to insert into the iliotibial band. This is sartorius. Sartorius arises on the anterior superior iliac spine. He's the longest muscle in the body. He's going to cross, he's going to come all the way down and insert on the medial aspect of the tibia. When you look at this portion, the medial aspect of the tibia, there are three muscles that are competing for the same spot. Sartorius, semitendinosus, and gracilis. Sorry, sartorius, gracilis, and then semitendinosus. So one from the anterior compartment, one from the medial compartment, one from the posterior compartment of the thigh. 3 muscles from 3 compartments, all coming down here, and they're attaching to the medial aspect of the tibia. So these 3 muscles, they look like a goose's feet. They're called pes anserina tendons. There's a gigantic bursa that sits underneath here that can get inflamed. There's a lot of bursae around the knee joint, and they can all get inflamed, okay? So that's the sartorius. Sartorius actions are often asked on the exam. It is a lateral rotator, flexes the hip, abducts the hip, and then it also flexes the knee. All these 3 muscles that you see here together that are inserting on the medial aspect of the tibia, which is the pes anserina tendons, they all flex the knee. Then you have vastus intermedius underneath. So this is the quads here, the most powerful extensors of the hip joint, knee joint, the most powerful extensors. That's why, like, anytime you have any kind of knee surgery, anything, the things that you want to work really hard, physiotherapists work, is the quads, because these quads support this knee joint tremendously. Then you come up here and you see iliopsoas. Iliopsoas is a unique muscle, right? Iliopsoas is one of those muscles that is actually arising on the lumbar vertebrae, which is really crazy. So it's arising on the lumbar vertebrae, and then it is coming all the way down. So it comes from the lumbar vertebrae all the way down, and it's going to the lesser trochanter here. Okay, it's inserting on the lesser trochanter. So this is the psoas major muscle. Iliacus comes from the iliac fossa. So psoas major is a powerful, both psoas and iliacus will, once the iliacus joins the psoas major, they go underneath the inguinal ligament, deep to the inguinal ligament. They come down, they form the floor of the femoral triangle, then they come down and attach to the lesser trochanter. This portion of it is psoas major, this portion, lateral portion, is iliacus. So we talk about it as one common tendon in the leg, because here they're separate muscles, but they come together, and then when they insert as one tendon called iliopsoas tendon. They insert on the lesser trochanter. It's the only muscle that inserts on the lesser trochanter. If you have an avulsion fracture of the lesser trochanter, it is the iliopsoas that is going to tear. Please know that. And the psoas major is extremely important to know, because here's a muscle that is actually attaching your vertebral column to your leg. What? Crazy. So it's coming from the transverse processes of the lumbar vertebrae, and it's coming down, and it's going into the lesser trochanter. Most powerful flexor of your hip joint is the iliopsoas, most powerful flexor. Who is his opposition? Who is the antagonistic muscle?
Gluteus maximus.
Gluteus maximus is the most powerful extensor of the hip joint. So 2 big gigantic muscles. One, gluteus maximus, we saw was going into the iliotibial band in the back. This is iliopsoas muscle, forms the floor. The other one that forms the floor of the femoral triangle is going to be this muscle here called pectineus. We like this muscle because we talk about this muscle, or we ask this muscle often, because it has 2 innervations. It can get innervated by femoral nerve and or obturator nerve. Okay, so these are all the anterior group of muscles. Quadriceps are very important in locking the knee when you stand. So there's the locking and unlocking of the knee joint. There's a slide on it on your PowerPoints. Please look at that slide. What muscle locks the knee joint is the quads. The muscle that unlocks the knee joint is popliteus. Okay, so these are the quads here. What else? These are the adductor compartment muscles. The order in which the adductor compartment muscles lie, superficial to deep, would be adductor longus here. Underneath it, a shorter muscle called brevis. Then a gigantic muscle called adductor magnus. I think I have a picture. Let's look at that. So this is the psoas major. Look, there it is, arising on the vertebrae, coming all the way down. This guy is an important muscle, okay? Then you have adductors. I don't have a picture of Magnus. Sucks. Okay, so adductor magnus is going to be the deepest, largest muscle. Adductor magnus is important for you to know, and I told you why, because it has 2 origins of insertion. So if you look at these origins and insertions from the PowerPoint, rectus femoris crosses the hip joint, right? And crosses the knee joint. All these other guys are just crossing the knee joint. So this guy will have a small function on the hip. And that's important to know. This is the medial compartment muscles. Pectineus is different because he has two muscles that can innervate him. Sometimes two do, sometimes only just one does. Then you have adductors. So when you, oh, here's the magnus. I do have a picture. Okay, so here's the adductor magnus. We like the adductor magnus. There's a couple of things to talk about the adductor magnus. First of all, he has two heads of origin. Maya, give me a second. One from the body of the pubis and the other one from the ischial tuberosity. So in this tiny little picture, there's a small portion that's arising on the ischial tuberosity. This is the ischial tuberosity. This portion is the adductor portion that's coming from the pubic bone. This portion is the hamstring portion. And they come down and this muscle fans out into this gigantic muscle, right? And it's coming down and it's inserting. So a portion of the adductor magnus, most of it is going to insert behind in the back on the linea aspera. Then some of it is going to come here and insert on a tubercle here. This is the condyle of the femur, medial condyle. On the medial condyle, you have a smaller bump. That's the smaller bump called the medial epicondyle. On the medial epicondyle, there's another small bump, and this bump is called the adductor tubercle. This tubercle was formed because this magnus kept pulling on this bone because it's a gigantic muscle, and it formed a little bump called the adductor tubercle. So this inferior portion of the adductor magnus has a gaping hole in it. This is called the adductor hiatus. This adductor hiatus is important for us. It's important because the femoral artery and vein are looking to get to the back to supply the back. So they get out, they come and they get out through this adductor hiatus. This is the opening, and they go to the back. This is the back that you're seeing here. They come out. As soon as they come out, they're called popliteal artery and popliteal vein. Okay, Maya.
So when you're talking about the obturator nerve in relation to like pectineus and adductor magnus, loss to the obturator nerve, does that just weaken those muscles since they have dual innervation?
Depends. If it was being innervated by the obturator nerve, then it'll weaken. It'll definitely affect the pectineus. So if pectineus is getting both the nerves, then it's not going to be affected too much. If pectineus is only getting one of the nerve innervations, either just the obturator nerve or the femoral nerve, and one of them is cut, then yes, pectineus function will be lost.
Okay.
Yeah. So because it's getting so sometimes it doesn't get both nerves innervating it, Maya. Well, sometimes only one nerve innervates it, either obturator or femoral. Okay.
Okay. And then for adductor magnus, because it has the two distinct functions, just the function related to the obturator
and the nerves are also
impacted.
different. No, the nerves are also different. So if the tibial component of the sciatic nerve, tibial component is completely severed, the hamstring portion will be affected. Hamstring portion of the adductor magnus will definitely not work. If the obturator nerve is affected, the hamstring portion will still work. But this portion here, the adductor portion will be lost.
Okay.
Yeah. I don't think we are smart enough to ask such detailed questions anyway. You give us way too much credit. Okay. So adductor magnus, right? Here's the foramina, femoral artery, femoral vein go through it. Another very important thing the adductor magnus does is look at all the holes it has in it. These are all for the perforating arteries. These perforating arteries are arteries that are coming off the profunda, which is the deep femoral. Deep femoral gives off 4 to 5 perforating arteries. Those perforating arteries pierce the adductor magnus, go to the back and supply the posterior thigh muscles. The posterior thigh does not have its own artery. It has its own nerve. It has no special artery supplying it, just like the back of your upper arm did not have a special artery. So you have this deep femoral artery gives off perforators that pierce and go to the back and supply the hamstrings. So the hamstrings get their blood supply from the perforating arteries, which in turn are coming from the deep femoral or profunda femoris. Okay. And that's again another obturator externus. Yes. Obturator externus is the deepest muscle in the medial compartment. And he's unique because he's a lateral rotator of your thigh. All of your lateral rotators are situated in the gluteal region. There are 6 lateral rotators of your leg, of your thigh. And 5 of them are situated in the gluteal region. One of them, this freak, is in the medial compartment. Deep in the medial compartment, he arises on the external surface of the obturator foramen, and he's going towards the trochanteric fossa, a small depression inside the trochanter, and he's going to laterally rotate. See, look at those fibers. If those fibers contract, they're going to laterally rotate the femur. So obturator externus, one of the lateral rotators, is situated deep in the medial compartment, whereas the rest of the lateral rotators are situated in the gluteal region. Also, this guy is supplied by the obturator nerve. The other lateral rotators in the gluteal region have so many different nerves supplying it, and they are important for you to know. You should know them. Obturator internus is supplied by a nerve called nerve to obturator internus. Piriformis is supplied by a nerve called nerve to piriformis. But then there's two other muscles called superior gemellus and inferior gemellus. You should know what nerves innervate superior gemellus and what nerve innervates inferior gemellus. Does anybody know that?
Is superior the superior or inferior? It, whatever the gluteus maximus or something, it's the same as that.
No, no.
Quadratus femoris.
Correct. So the inferior gemellus is supplied by the nerve to quadratus femoris, and the superior gemellus is supplied by the nerve to obturator internus. Okay? Superior gemellus is supplied by nerve to obturator internus. Inferior gemellus is supplied by nerve to quadratus femoris. Okay, so there is one muscle in the medial compartment that we haven't talked about yet, which is gracilis. Gracilis is this thin strap-like muscle. This is the muscle that formed one of the pes anserina tendons, right? So there's all these muscles that are doing adduction, but gracilis is also doing flexion at the knee. Flexion at the knee, because that's important to know. So see gracilis, he helps flex his leg because he lies and rotates the leg medially because he's lying along with these other pes anserina tendons that I talked about earlier, and I don't know where that picture is, and I don't feel like going back there. Right here. So here it is. So this is where you have sartorius, there's gracilis coming down, and semitendinosus from the back. So this gracilis muscle not only is an adductor, it has also got a function on the knee joint because he's crossing the knee joint and he's going to do flexion at the knee joint. Okay? So these exceptions to the rule always is what people ask. So make sure you look at the exceptions. You guys all know about the femoral artery. Here's the femoral artery. It's a continuation of the external iliac. He comes down below the inguinal ligament. He's going to change his name to femoral artery. He gives off some superficial branches that we don't care about. Then he gives off a large branch here called the deep femoral artery. This is the deep femoral artery that's here. The deep femoral artery gives off very important branches: lateral femoral circumflex and medial femoral circumflex. I don't know if I have a picture of, and I'll show you those branches and talk about them in detail in a second. But there's the profunda coming down, giving off perforators. And this is, you know what, clinicians call this the superficial femoral artery. So when you go into clinics, don't forget when they say superficial femoral artery, they're calling this superficial because this is called deep femoral. Makes sense, right? But we just call it femoral. But this is the continuation of the femoral. He supplies a bunch of muscles here as he's going. He's going through the femoral triangle here, then he goes through the adductor canal. He leaves through the adductor hiatus, becomes the popliteal artery in the back of the knee. Okay? Femoral triangle, definitely should know femoral triangle. Clinically, one of the most important areas that we constantly access for cardiac catheterization and to catheterize the right heart and the left heart. So here is the femoral triangle. This is the inguinal ligament, which is the superior boundary. Sartorius is the lateral boundary. Adductor longus is the medial boundary. Here are the contents of the femoral triangle. The most medial structure here that you see that is empty is the femoral canal. This area here is the femoral canal. It just contains some lymphatics and a lymph node, one single lymph node. Then you have the femoral vein, artery, and nerve, right? Vein, artery, and nerve, vein, artery, and nerve from medial to lateral. But the most medial thing here is the femoral canal. This femoral canal actually has a ring on the top. It's called the femoral ring. You can actually put your pinky through this femoral ring. So that femoral ring is important to know. So then this femoral vein and the femoral artery and the femoral canal are all enclosed in a really dense fascia called the femoral sheath. The nerve is not in the femoral sheath, not. Femoral nerve is outside the femoral sheath, a very dense sheath. For those of you who did the dissection, you would have noticed that you had to really cut through the femoral sheath. So vein medially, artery laterally, Femoral nerve more laterally, but not a component of the femoral sheath. Femoral canal is the most medial structure with the femoral ring that it opens into. Floor of the femoral triangle is formed by pectineus and iliopsoas. Those are the two muscles there. This is important to know, guys. This we often ask. So here is, stay with me for a second. So here's the inguinal ligament, right? Anterior superior iliac spine to the pubic tubercle is the extent of the inguinal ligament. The inguinal ligament has, let's do this. The inguinal ligament, so if you look, this is the femoral sheath, right? This is the femoral sheath. The nerve is outside the sheath. Within the femoral sheath, you see it exactly is like a conical cup-like sheath, like one of those little paper cups that you drink from. So it's exactly like that. It's conical. It encloses the femoral canal. The canal has a lymph node and some lymphatics in it. Femoral vein is right there. Femoral artery is right there. And then this is what is found in the sheath. This is the femoral ring. Look at this femoral ring for a second. Here is the inguinal ligament. This inguinal ligament comes from the anterior superior iliac spine, goes to the pubic tubercle, and this inguinal ligament, when it attaches to the pubic tubercle, it suddenly makes a sharp turn and goes around like this. This sharp turn that the inguinal ligament makes is called the lacunar ligament. In fact, when you put your finger into this femoral ring, your pinky into the ring, it can literally cut you. It's a very, very sharp turn that the inguinal ligament takes. And this portion of the inguinal ligament is referred to as the lacunar ligament. You see these fibers, all these fibers here? This sharp turn that it's making, this portion here is the lacunar ligament. This is the femoral ring. Often questions will ask you, here's a surgeon that's repairing the femoral hernia. He puts his finger into the femoral ring and he feels the medial margin of it to be really sharp. What forms that medial margin? It's the lacunar ligament, okay? The other thing is, because it's so sharp, this lacunar ligament, when you have a femoral hernia, if the hernia is coming through here and it's bulging down, this lacunar ligament is so sharp that it can strangulate it. If it's a big piece of intestine that comes through, it can strangulate it because of its sharp margin. But this relationship of this femoral ring medially to this lacunar ligament is surgically very, very important and often asked in questions. So please know that its relationship, the femoral ring's relationship here is the lacunar ligament. I need 5 minutes to like really get some water and pee. Can you give me 5 minutes and I'll be back? Please.
Yes.
Yeah.
Okay, I'm back. Okay. So we were talking about the femoral triangle. We're talking about the contents of the femoral triangle. We talked about this femoral canal. This femoral canal has a ring called the femoral ring. We talked about its medial boundary being formed by this inguinal ligament that is actually just going around, forming the sharp margin, and attaches to this bone here. So as it turns around with its attachment, it causes the sharp edge here, and this whole area here is called the lacunar ligament. This is an important relationship to know. And then underneath the inguinal ligament, this entire space here is called the subinguinal space. Subways, right, underneath the inguinal ligament. So subinguinal space. In the subinguinal space, you have two compartments. This compartment here laterally is called the muscular compartment. This compartment here is called the vascular compartment. So this is the muscular compartment, and what the heck is coming through in the muscular compartment? That's the iliopsoas. The psoas major and the iliacus have formed a common tendon now, common muscle here, and that lies in this lateral compartment here underneath the ligament, inguinal ligament, and it's going to its insertion on the lesser trochanter. The femoral nerve takes a ride in the muscular compartment, right? So he goes along in the muscular compartment with these muscles, which is iliacus and psoas major. This is called the vascular compartment, which contains the femoral canal, the femoral vein, and the femoral artery. So this is the femoral triangle. It's clinically extremely important because this is a great way for us to gain access to arteries towards the heart and arteries towards the leg. Okay, so this is a great way for us. So peripheral vascular disease is very, very common. People who are diabetics get peripheral vascular disease. Anybody with, many different conditions. But and of course, coronary blood vessels can easily get blocked off by fat. So cardiac catheterization is done daily or constantly, and they gain access through the femoral artery. You go through the femoral artery, put a catheter, go up, shoot up a dye and look at the coronary blood vessels, or you can go downwards and shoot up a dye and see what is happening with the branches of the femoral artery. Are the femoral artery branches blocked? And is that what's causing pain in these muscles, right? So we can do that. And then we can use the femoral vein to go to the right side of the heart, because the right side of the heart is venous. So we can go to the right ventricle. We can measure pressures. There's so many conditions in which we do cardiac catheterization. We can catheterize femoral vein or the femoral artery. So this is very, very commonly done, and it's important for you guys to know. So that's about the femoral triangle, which is extremely important to know. We talked about the femoral hernias. There's a gigantic loop of intestine coming. That's the femoral ring. And there's the lacunar ligament medially. Adductor canal. So this is the femoral triangle here. When the apex of the femoral triangle, when the femoral triangle ends, the adductor canal will begin. Daphne.
So the major clinical correlate for the femoral triangle is cardiac catheterization, like being able to access the
cardiac catheterization from the femoral artery and also through the femoral vein, and femoral hernias. Yeah.
Okay, thank you.
So this one here is underneath. So this is the sartorius that forms the lateral boundary. Adductor longus forms the medial boundary. When they two meet at the apex, another canal begins, another passageway begins underneath the sartorius. This is called the subsartorial canal because it's underneath the sartorius, or the adductor canal, or the Hunter's canal. These are all names for the same canal. And all it's doing is it's got few structures in there, and we want to know what those structures are in the adductor canal. So please know the boundaries, memorize them. So what lies anterior, what forms the floor, what forms the roof. You could do that. You could read it on your own. The contents are important to know. It contains the femoral vein and the femoral artery. I wanted to show you a picture of something that was important in my head, and I just now don't have a picture, do I? I do. Okay, so here is the femoral triangle, right? So this is the adductor longus, this is the sartorius, this is the apex of the femoral triangle, this is the base of the femoral triangle here. So here is where the adductor canal is going to begin, underneath the sartorius. So the femoral vein, so notice how the femoral vein is medial. So this is medial, this is the pubic bone. Sartorius originates laterally. This is the femoral artery. Femoral artery is initially lateral to the femoral vein. Slowly, when you come into the sartorius, underneath the sartorius, underneath the adductor canal, one of the important anatomical relationships that changes is that the femoral artery will lie on top of the femoral vein. Initially, it's lateral to it, right? You see how it's lateral to it initially. This is medial, this is lateral. And then as he's coming, he slowly crosses over and lies on top of the femoral vein. In the adductor canal, the femoral vein is the most superficial structure. So if you ever have any stab wounds in the adductor canal, if somebody stabbed you near the adductor canal, the most this big gigantic guy will bleed. So I want you to know that the femoral artery is the most superficial underneath the adductor canal. There's the femoral vein. And then there's a couple of nerves. So the contents of the adductor canal are often asked on the exam, which is nerve to vastus medialis and our friend saphenous nerve. The saphenous nerve lies in this adductor canal. So if you look at this picture, it's going to tell you femoral vessel, saphenous nerve, and a nerve that they didn't mention here. Nerve to vastus medialis, a nerve called nerve to vastus medialis. So 4 things lie in the adductor canal: femoral vein, femoral artery, saphenous nerve, and nerve to vastus medialis, guys, which is just a nerve supplying vastus medialis. That's this guy. See this guy? He's coming and supplying vastus medialis. Yeah. So these are the 4 contents, and that's the adductor canal. And of course, he comes down. When he comes down, he's going to find that adductor hiatus, the femoral artery and vein, and they're going to leave through the hiatus and go to the back. These are the muscles that we talked about. This is a popular question that often is asked, this cross section. This is the one cross section that's sometimes asked. This is the cross section of the leg, where now we've come down to the leg. This is the tibia, the larger bone. Here's the fibula. This is the interosseous membrane. And then we talked about these 2 intermuscular septi that are attaching to the anterior border and the posterior border of the fibula, and closing the lateral compartment. This is a great way to just study the compartments. And look, this will tell you all of these compartments, what nerves it supply, what nerves are lying in here. Let's look at it. Anterior compartment. Anterior compartment lies anterior to the interosseous membrane, and it contains tibialis anterior, extensor hallucis longus, and then it contains extensor digitorum longus. So these 3 muscles. What is the nerve for the anterior compartment of the leg? Deep fibular nerve. What is the artery for the anterior compartment? Anterior tibial artery, which is coming off from the popliteal artery, right? The popliteal artery will divide into anterior tibial and posterior tibial. We'll look at a picture in a second. This is anterior tibial and deep fibular nerve. So you should know compartments. You should know compartments, what nerve and what artery is in that compartment. Lateral compartment, pay attention, lateral compartment has no artery. It has no artery. It has a nerve. The nerve that supplies the lateral compartment is the superficial fibular nerve. It has 2 muscles, fibularis longus and fibularis brevis. Longus is on top, fibularis brevis is underneath it. No artery. What the heck is supplying this lateral compartment? What supplies the lateral compartment is a branch from the tibial artery, okay, posterior tibial artery. So we'll take a look at that in a second. This is the gigantic posterior compartment. This gigantic posterior compartment, which is the calf of your leg, is further divided into a superficial compartment and a deep compartment by a septum. This septum is called a transverse intermuscular septum. This deep transverse intermuscular septum, we in our lab ask this sometimes on the exams. Please don't freak out. I'll make sure that we don't ask it this time, but we do sometimes ask it when you have time to do. This particular, module system is not allowing us to be in that detailed. But this is a septum here called the deep transverse intermuscular septum that separates the posterior compartment into a large superficial compartment and a smaller, deeper compartment. Both are posterior compartments, by the way. This is the superficial posterior compartment. This is the deep posterior compartment. Okay, so what is the blood vessels for this posterior compartment? Tibial nerve, big, gigantic nerve, gigantic nerve. And then there is the posterior tibial vessels, each vessel accompanied by accompanying veins. This posterior tibial artery gives off a branch in the calf, and that branch is called the fibular artery. This fibular artery lies laterally. This fibular artery is actually going to send perforating branches to supply the lateral compartment. You also get some perforating branches from the anterior tibial, but the fibular artery takes the big load, and he supplies quite a bit of these muscles because this group, this lateral group, doesn't have its own blood supply. Okay? So this is anterior, this is posterior, this is lateral. Deep fibular, tibial, superficial fibular. Anterior tibial artery, posterior tibial artery, and fibular artery. Fibular artery helps out the lateral compartment. So this is a good way to know your compartments. Muscles of the posterior compartment, gastrocnemius and soleus form this gigantic muscle. It's called the Achilles tendon. Achilles tendon is the thickest, biggest tendon in the body. It is the strongest tendon in the body. Even these Achilles tendon often can rupture. You can get tendon ruptures just from getting old and also from playing sports. So here is this Achilles tendon going to its insertion on the calcaneus.
Good question.
Yo, yes.
Did you say the gastrocnemius and soleus form the Achilles?
Yes.
Okay.
Gastrocnemius and soleus will combine to form one common tendon called the Achilles tendon. Plantaris is a tiny little muscle that lies in the posterior compartment. It was like the palmaris longus that we had in the flexor compartment. Nobody cares about it. But anyway, there it is. It forms a long, thin tendon. We only care about it when we have to do tendon transplants because it has a long tendon. It looks like a nerve. Often this tendon is referred to as a student's nerve because students, when we ask this in the practical, they pick it and they look at it and they think it's a nerve. It's not a nerve. It's actually a tendon. It's a very thin tendon. That's plantaris. Gastrocs and soleus. What do you want to know about the gastrocs? Well, gastrocs are the only muscle in the posterior compartment that's crossing the knee joint, because it arises on the posterior aspect of the condyles of the femur. So big muscle. And these guys are so important in pushing the blood back. Thousands of perforating veins go through this gastrocs and soleus muscles. Here is the soleus. Soleus is not arising. It rises on the tibia on a soleal line. He's not crossing the knee joint. You can clearly see gastrocs cross the knee joint and they cross the ankle joint. So that's the Achilles tendon. Erin.
Quick question regarding the Achilles tendon. There was one question in class where they said like the Achilles tendon was ruptured, and would you lose plantar flexion completely or would you not, because you still have those that are in the deep compartment?
The deep compartment muscles, specifically tibialis posterior, does plantar flexion. Achilles tendon is a very powerful plantar flexor. So you'd lose a lot of plantar flexion. So when your Achilles tendon ruptures, you do get, you are unable to plantar flex it. You don't completely lose it. A lot of these muscles will take over, but you don't lose it completely for sure.
Okay, thank you.
Did the question say that you completely lose
Yeah,
it?
there was like, we didn't get to it in class, so I didn't know if the answer was, it says, what do you lose?
Is it
And
my
it was either
question?
I don't remember. It was like in an interactive session, but it was
With me?
plantar
Norma?
flexion of it's Middletown.
Oh, in Middletown. Okay. I don't have access to the Middletown questions, but if you send it to me, I could look at it. You don't completely lose it, but it's a pretty big, look at the gigantic muscles. They have quite a lot of power as far as plantar flexion is concerned. So you don't completely lose it. Tibialis posterior will do it. Flexor digitorum longus, flexor hallucis longus, as they're going down, they can also assist in it and you kind of compensate with it, but you don't lose it completely.
Okay, thank you.
Yeah.
Wait, Dr. Edge?
Yeah.
A quick question regarding the cross-section picture. Would you say that the flexor hallucis longus gets its blood supply from the tibialis or from the fibular artery? The tibial artery or the fibular?
Flexor hallucis longus muscle. So in the posterior, that's a very specific question. So this is the tibial artery, and here's the fibular artery. So because flexor hallucis longus is kind of more lateral, it'll probably get its blood supply from the fibular portion of the tibial artery. Tibialis posterior definitely is supplied by the tibial artery, and flexor digitorum longus probably gets both.
Okay.
Those are very specific questions. Do you have questions like that?
Yeah, I saw one question about what blood supply does the flexor hallucis longus get?
And did it say fibular artery and tibial artery?
Yeah.
Where was this?
Maybe it was like a boot camp question or something.
Is it Middletown here? Where?
No. It was like maybe it was an outside resource.
Are you from Harlem?
Yeah.
Oh, bring the question to me, girl.
Okay, thank you.
Yeah, send it to me. Okay, so this is all about the muscles. You know about gastrocnemius is the one that we use for jumping when you're actively doing stuff. It's gastrocnemius. Soleus is the one that is actively working when you're just strolling. S and S stand. Soleus stands for strolling, kind of. That's how I remember it because it's just a larger muscle. And I just remember this picture of walking with the dog. Calcaneal tendon, you know about the bursies. These bursies are very commonly inflamed. So the bursa that is superficial is called the subcutaneous calcaneal bursa. And then when there's one that is deeper between the Achilles tendon and the calcaneus itself, which is called a retrocalcaneal because it's behind the calcaneus, between the calcaneus and the Achilles tendon. And this one gets inflamed very commonly in runners. So you get pain along the back of the leg, inflamed, red, all of that. Also, something I don't know if I mentioned in my video, but just so you know in your clinical practice, the Achilles tendon doesn't have a very good blood supply. It has an area called the watershed area in its tendon, and often that's one of the reasons they think that it ruptures. This tendon can rupture in sports because, people always wonder how come this is such a big tendon and how could it rupture? It does have an area where, it's called a watershed area. You'll learn about it later. This is the anterior compartment muscles, tibialis anterior. Tibialis anterior and posterior share the common action of inversion at the subtalar joint. One does dorsiflexion, the other one does plantar flexion. So that's important to know. And these guys tell you what they do. Extensor hallucis extends the big toe, extensor digitorum extends the digits. All of these guys are can you please give me 1 second? Okay, so out of this, one of the things that's important to know, of course, we all know that the deep fibular nerve supplies all of these muscles. Fibularis tertius. Fibularis tertius is an odd guy because he does dorsiflexion and he also does eversion. So fibularis, just by the name fibularis, he belongs to the fibularis longus and brevis groups. He does eversion. Okay, so he does dorsiflexion, but he also does eversion. So often when there's deep fibular nerve injury, you can have slight weakness in eversion because the fibularis tertius is going to be affected. So that's like an odd one out that is often asked on the exams. What is a muscle that does dorsiflexion and does eversion? As far as plantar layer muscles are concerned, please don't knock yourself out with origins and insertions. Please know the following. Know what muscles belong to what layer. First layer, second layer, third layer, and fourth layer muscles. And know what nerves supply them. That's pretty much what we want you to know. Which nerves, the names will tell you what they do. Abductor hallucis will do abductor hallux, abductor digitominimial abduct, flexor digitorum flexus the toe. But you want to know the nerve supply. What nerves supply what muscles? If you know that, that would be really good. Okay. So second layer. So this is the second layer muscles. Why is the lateral compartment here? Oh, I don't know why the lateral compartment is here, but that's fibularis longus and brevis. You guys know both are powerful everters, guys, very powerful everters supplied by the superficial fibular nerve, which is important to know. These are the layers, second layer, third layer, know the layers. No, okay. One of you sent me an email. There's a mistake on one of the PowerPoints, I think. The palmar interossei will only go, the palmar interossei doesn't go to the first and second toes. It only goes third to the fifth toes. It only adducts third to the fifth toes. I think on the PowerPoint it said second to the fourth toe or something like that. But if it is saying that, please make a correction. Palmar interossei are found third, fourth, and fifth, okay? And palmar interossei do adduction, pad, and dorsal interossei will do abduction, just like the interossei in the hand. And all of the interossei are going to be supplied by lateral plantar nerve. So if you're spreading your toes like this, you're doing abduction. The second toe is the center for the foot. Here it was the middle finger, right? The middle finger, I like doing that. The middle finger was for the hand. And so if you went away from the middle finger or towards the middle finger, it was abduction and adduction. Here, abduction and adduction is the second toe. If it's going towards the second toe, it's adduction. If it's going away from the second toe, it's abduction. So when you spread your toes, you're doing abduction. Okay? Hip joint. I don't know why so many of you, trochanteric anastomosis, cruciate anastomosis, you're freaking out. Here we go. Hip joint, ball and socket joint, like the shoulder joint, lots of movement is possible. It has a capsule that goes around, and it has extracapsular ligaments. There are 3 ligaments for the hip joint. The one that is anteriorly found here, this is called the iliofemoral ligament, the strongest ligament, the most important ligament. He's a Y-shaped ligament. He's also called the ligament of Bigelow. Obviously, a Bigelow guy found it. There you go. That's the inverted Y-shaped or inverted, Y-shaped ligament. Found anteriorly, attaches along the intertrochanteric line. This here is called the pubofemoral ligament, runs from the pubic bone towards the it actually merges with the capsule. It lies medially. And then posteriorly, this twisted convoluted ligament, this lies posteriorly, is called the ischiofemoral ligament. Look at its fibers, they're all curving around and coming and attaching, right? So these are the three capsular ligaments. Then you have an intracapsular ligament on the head of the femur. Some people consider it to be actually synovial membrane that becomes thicker. But this is on the head of the femur, there's a little pit called the fovea. From there, you get a ligament that goes into the acetabulum, into the acetabular fossa here. This is called the ligament of the head of the femur. The ligament of the head of the femur contains an artery in it called artery to the ligament of the head of the femur. So inside this ligament, there is an artery. There's an artery, and the artery is called artery to the ligament of the head of the femur. So, well, all these three ligaments, you guys know by now that ligaments attach bones and their function is to prevent excessive movements of bones at a joint. All three ligaments, iliofemoral, ischiofemoral, and pubofemoral, all of them will prevent hyperextension. If you look at your hip joint and if you stand and you flex and extend your hip joint, you'll find that there's way more flexion you can do than extension, because all these ligaments will limit extension. So you can only go so much back. After that, you can't go further back any further because the ligaments will limit extension. So all three ligaments will limit extension. Pubofemoral ligament will limit abduction because it's found medially, right? So it'll prevent this guy from going too far away from the midline of the body. So pubofemoral limits abduction. Those are the three ligaments. The other two ligaments are unimportant. Okay. Ligament of the head of the femur, we're going to talk about it when you do blood supply. Okay, here we go. Blood supply, blood supply, blood supply. Let's look at it. The blood supply, there are three things that do the blood supply: medial femoral, lateral femoral, and branches of the deep arteries, which are usually these two are branches of the profunda. That's what I meant to say. Medial femoral, lateral femoral. And then there's a small contribution from a small artery to the ligament of the head of the femur. So let me tell you about this artery to the ligament of the head of the femur. So here's the head of the femur. Here is an artery. This artery, called the ligament artery to the ligament of the head of the femur, he's coming from the obturator artery, which is going to supply the medial compartment. As he's coming down, he comes from the internal iliac artery, which you haven't learned yet. But he comes, and as he's coming towards the medial compartment to supply the medial compartment muscles, he throws off a branch. This is called the ligament of the head of the femur. Pay attention now. This artery is extremely important during intrauterine life. It is really important for the head of the femur to grow. He supplies the head of the femur. He is vibrantly supplying this head of the femur in the intrauterine life, in a neonate, 6 months, 7 months. It is pumping blood, and it is helping the head of the femur and surviving the head of the femur, or helping the head of the femur survive. As you get older, this slowly closes off, and there's less and less blood flow that comes through. Now, don't forget, this artery is inside that ligament of the head of the femur. In some people, it closes off completely. In some people, it'll just remain, but it gives insignificant amount of blood to the head of the femur. So the head of the femur in an adult has to depend. So it doesn't have anything separately coming to supply the head, you see. In the child, this one was supplying it. But 16 and 17, it's probably very little blood coming from here, and he's not helping with the supply to the head of the femur. The head of the femur now has to depend on the circumflex arteries. Having said that, in a child, if you have a thrombus here, right? If you're 3 months old, 4 months old, 2 years old, if this artery gets a blood clot, you can have avascular necrosis of the head of the femur, which means avascular, meaning no blood supply, which means no oxygen to the bone's going to die. Very similar to the heart. If you don't have blood supply to the heart is unable to pump, so ischemia and the muscle dies, right? Same thing, bone will die, brain will die. Every organ in the body depends on blood supply, which is bringing oxygen. So this guy, in a child, in a little baby, if this gets closed off, or if this one, not closed off, if there's a thrombus here, a blood clot here, you'll get avascular necrosis. If you have a fracture that cut the ligament of the head of the femur in a little neonate, yes, you can get avascular necrosis. In an adult, it's unimportant. Okay, it's not important because in an adult, we're depending on medial femoral circumflex and lateral femoral circumflex. MFC and LFC are coming off the profunda. Watch this. This is the head. This is the neck. This is the greater trochanter. That's going to be, here is going to be the lesser trochanter, and here's the lateral femoral circumflex. Medial femoral circumflex comes off the profunda and he goes posteriorly, right? He goes towards the back and he exactly crosses the neck, or as he's going to form this anastomosis we're going to talk about. Lateral femoral circumflex is given off a little more distally, not like at the neck, as you see. He's given off close to the greater trochanter, and he's also going around and making this anastomosis. So like I say to my kids in Harlem, I'm going to tell you guys, if I say hip joint blood supply, you say medial femoral circumflex. I say hip joint blood supply, what is the most important thing? You say medial femoral circumflex. More than lateral femoral circumflex, medial femoral circumflex, as it's going towards the back, supplies an extensive area of the head and neck, and so it's an extremely important artery for the hip joint. Okay? Having said that, the other thing you have to remember is each of these arteries, when they're given off, they divide into 3 branches. Okay? So take a look at this lateral femoral circumflex. He divides into an ascending branch, a transverse branch here, and a descending branch. Ascending branch is going up. Now he's going close to the base of the neck. He's going up there and he's going to anastomose with the ascending branch of the medial femoral circumflex. You don't see the medial femoral circumflex here because he's towards the back of the neck. So, first of all, inherently in this long bone called the femur, the neck is just a weak area. Anytime fractures occur usually at the neck, but also it is at the angle, the way an injury can occur, it can crack this. You know, there's many different factors, but neck fractures are very common, having said that it is also inherently weak. In women, especially after menopause, because of lack of estrogen and lack of enough testosterone in our body, these bones become fragile. So when these bones become fragile, it's always, anytime a patient with osteoporosis falls, you break the neck of the femur. Okay, when they say hip fracture, they're talking about neck of the femur, you know. They're not talking about your pelvic bone fracturing. They colloquially, they call it, oh, I broke my hip. You're like, oh, you broke your femoral neck. So you broke your femoral neck because that's what happens. The femoral neck, the artery that's predominantly going around the femoral neck is medial femoral circumflex artery. So always in any question, if they're asking you which artery bled, which artery is causing the avascular necrosis, don't get confused between all the choices because you do know that they're all supplying. Lateral femoral circumflex surely supplies the femur, but it's always the medial femoral circumflex we're looking for, okay? Medial femoral circumflex is the most important artery, and when you have fractures of the neck of the femur in older patients, this is the medial femoral circumflex that's going to affect the neck, and you will get avascular necrosis. So avascular necrosis is a complication that orthopedics want to prevent in women or in men who are at the age of 9. Women, everything happens earlier, and men, it happens later. But when you fall and you have a femoral neck fracture, we are worried about avascular necrosis because it could have disrupted the blood vessels, especially the medial femoral circumflex. Okay? So medial femoral circumflex, blood supply to a hip joint in an adult, MFC. In a child, if you're talking about avascular necrosis, it surely could be that obturator branch. So sometimes we do ask about it. Is that clear, guys?
Yes.
Yes, thank you. So that's about the blood supply. And then there's a bunch of anastomoses. This anastomosis always kills people. I don't know why, but it's very simple. There are two anastomoses that greatly supply the hip joint. One is called the trochanteric anastomoses. The other one is called the cruciate anastomoses. This one that you're looking at is the trochanteric anastomoses. Trochanteric anastomosis is taking place at the greater trochanter. Okay. What participates in the anastomoses of the greater trochanter is going to be ascending branches. Ascending branch of MFC, ascending branch of LFC, a branch of the inferior gluteal artery that has no name. It's just called a branch of inferior gluteal, and a branch of the superior gluteal. Those take part in this anastomosis. And this is the most important blood supply to the head of the femur in an adult. Along the greater trochanter, these guys are throwing off branches called retinacular branches. They go up, all kinds, metaphyseal branches, epiphyseal branches, a bunch of branches. All of those from this anastomosis go and supply this area. So ascending branches of the two circumflex arteries, superior gluteal and inferior gluteal, if you see that, that is trochanteric anastomosis. And that's the main blood supply to the head of the femur. The other blood supply to the head of the other anastomosis that supplies the hip joint is called the cruciate anastomosis because it looks like a cross. Here, the transverse branches are anastomosing. Transverse of LFC, transverse of MFC, inferior gluteal still, but this time an ascending branch from the perforating artery. That perforating artery is coming off the deep femoral. These guys, there are 4 or 5 of these perforating branches, and they're supplying the hamstrings. So the very first perforator will take part in the anastomosis of the cruciate anastomosis. Okay, this also supplies, and it supplies the distal part of the hip joint. So these are the two anastomoses, and it's as simple as that. So don't kill yourself. Just know what arteries take part and what is the most important blood supply. MFC, MFC, MFC. So in children, avascular necrosis can occur for several reasons. You'll learn all of this, and there's a disease that you don't even need to know. Leg, calf, Perthes disease, it's called. Don't worry about it now. You'll learn it in orthopedics. But you can be born with a dislocated hip called congenital dislocation. And I didn't put those slides in because I know you would read it, and I don't think I have time. I was going to do an hour and a half maybe review, but we're way ahead of way far. So congenital dislocations are common for those of you who have babies. The very first time you take your little baby, neonate, for the first month, well visit is called. After you're born, you take it at the end of the first month, and they'll check the thighs. They'll do these tests called Ortolani test and Barlow test. Those tests are done to see if this kid is born or this baby is born with a congenital hip dislocation, because it's very common to have a congenital hip dislocation. Traumatic hip dislocation happens in adults. The most common traumatic hip dislocation is posterior. In the shoulder joint, the most common dislocation was inferior, because inferiorly there was nothing protecting, rotator cuff was on top. In the hip, it's most often posterior. So it's often usually because of the type of injuries that happen. So if you're driving dashboard, you flexed knee, you hit the dashboard with the flexed knee, you push that femur back, and you are pushing it back in through the acetabulum, you're dislocating it posteriorly. When you have a posterior dislocation of the femur, the nerve type of dislocation, 90% of dislocations are posterior dislocations. When you have this common type of dislocation, the nerve that is in the back is the sciatic nerve. The sciatic nerve can be compressed. Also, look, this thing is now going posteriorly, so your leg is going to be shortened. So whichever leg has the dislocation will be shorter, okay? It'll be adducted. So you should know the dislocation and how the leg will present. The leg will definitely be shorter because it's being pushed posteriorly. So this is anterior dislocation I'm showing you. This is posterior. So the affected limb will be definitely shortened, and it'll be internally rotated because it's going towards the back. So this is highlighted for you on the PowerPoints because you should know that. And that's a traumatic posterior dislocation. Anterior dislocations are not as common. Central dislocations are not common. But for now, if you know this, you're good. Okay? Then you have what is this? Oh, knee joint. Darn it. Okay, so the knee joint. I'm running out of steam, people. So let's look at the knee joint. What do we want? This knee joint. Okay. So there are extracapsular ligaments, there's intracapsular ligaments. The extracapsular ligaments that you have are several. One of the two important ones I'm going to talk to you about, extracapsular, they're outside the capsule, is the fibulocollateral ligament and the medial collateral ligament. Fibulocollateral ligament is the lateral collateral ligament. He's running to the head of the fibula, coming from the medial collateral condyle. And this guy, underneath it lies the popliteus tendon, coming from its origin. There's a bursa here, okay? Anyway, this is the fibulocollateral ligament. It's cord-like and it's very strong. Tibial collateral ligament is flat and it is band. It's much weaker. It's like a band and it's much weaker. It's supposed to have two parts to it, a superficial part and a deep part. It is the deep part of the tibial collateral ligament that has an attachment to the medial meniscus. This is a problem. So if the medial meniscus tears, tibial collateral will tear. Not always, but it can, more likely can. If the tibial collateral ligament tears, it can snap off a piece of the medial meniscus, and you can get a little piece of the medial meniscus off. We don't have such a connection with the lateral collateral. So this connection is important for us to know. So this is a problem. These are the intracapsular ligaments inside the joint. These other two guys were outside the joint. This one is the anterior cruciate ligament. This is the posterior cruciate ligament. Pay attention now. We call this ACL because of its attachment to the tibia. We call this PCL because of its attachment to the tibia. ACL attaches anteriorly on the tibia, hence anterior cruciate ligament. Posterior cruciate ligament has an attachment posteriorly on the tibia. So if you remember that, you're good. ACL is going to arise from the anterior attachment on the tibia. It goes posteriorly to the condyle of the femur. PCL arises posteriorly on the tibia, comes anteriorly to attach. We know the function of ligaments is to prevent excessive movements. Here is this ligament, anterior cruciate. This anterior cruciate ligament is tightly holding on to this condyle. So what it's doing is, if you still have energy, pay attention. It is preventing the tibia from moving excessively forward anteriorly because it is attached anteriorly. And it's preventing posterior displacement of the femur because these femoral condyles can roll back. They are rounded condyles. So it's like two balls on a table. They can just roll off. So this guy will hold on to the posterior aspect and he'll prevent the posterior displacement of the femur or anterior displacement of tibia. Need to know this in that much detail in order for you to understand. Because it arises anteriorly, it's going to prevent anterior displacement. Because it is attaching posteriorly on the femur, it's going to prevent this guy from rolling back. He's going to hold on to it. PCL does the opposite. So ACL is the weaker one, less blood supply. He tears often. And if he tears, what happens is this tibia will pull forward anteriorly. Okay? So know the attachments of these ligaments, which will then give you an idea of what happens with these. I'm going to remind me to come back to that picture, this cross section here again. So this is how anterior drawer sign and posterior drawer sign are important for you to know. I'm just going to get to anterior and ACL tears. So here you have your two thumbs, usually on either side of the tibial tuberosity. You cup the entire calf, depending on how big the calf is. If you can't cup it, then you probably will have to put your fingers further away from the tibial tuberosity. And you pull the tibia anteriorly. If I can move the tibia excessively anteriorly, that means this guy is torn. So he's not able to hold on to the anterior portion of the tibia. And this guy will come forward, this guy will roll back. Femur will roll back, and this is called the anterior drawer sign. It's like pulling a drawer out. This tibia is coming out. PCL will be the same thing, but in the opposite direction. You put your fingers just the same way and you push the tibia. If the tibia is moving excessively backward and the femur is coming excessively forward, that is a posterior drawer sign. Do you understand that?
Yes.
Thank you. Okay, ACL tear and PCL tears are important in anterior drawer sign. Know the origins and insertions of the ligaments, right? And then there is the medial collateral and lateral collateral ligaments. Well, it's a very simple thing, guys. It's a very simple concept to kind of remember. I'm trying to get to this picture here. So if there's a lateral blow, everything shifts medially and it'll tear the tibial collateral ligament. If there's a medial blow, all of this shifts laterally and it's going to tear the lateral collateral ligament. So blows to the knees will decide which ligament is going to tear. ACL, this unhappy triad that we have, is an important triad. Often, this is a very sad triad because ACL is already weak. ACL will tear, medial meniscus will tear, and tibial collateral ligament will tear. That is the unhappy triad: ACL, medial meniscus, and tibial collateral. In order for all three to tear, you kind of have to have a posterolateral blow. Somebody that's got, if you have your knees bent and somebody tackles you from the back and smacks you in the back and laterally on the knee, you're going to tear the ACL, you're going to tear the tibial collateral ligament, and you're going to tear the medial meniscus. Okay? So that is really what happens in an unhappy triad. The other thing also to know, these two ligaments are extracapsular, lateral collateral and tibial collateral. Look, this is the capsule. They're outside the capsule. Okay? Except for a portion of it that is attaching to the medial meniscus, but that's an attachment to the medial meniscus. These two ligaments, cruciate ligaments, are intracapsular and extrasynovial. They're outside the synovial membrane. The synovial membrane, which is red in color, goes around and it avoids the cruciate ligaments, and it literally divides this knee joint into two compartments. Okay? Two compartments here. So just remember that the cruciate ligaments are intracapsular and extrasynovial. Okay, I'm running out of steam. I don't know if I covered everything you needed me to cover, but there was one. Yes.
Sorry.
Yes.
You had said to tear the unhappy triad, you said posterolateral blow. Do you mean posterior medial?
Posterolateral blows, because lateral blow will tear the medial collateral.
Okay.
And
Okay.
yeah,
Sorry.
yeah.
Okay.
Look at the
towards medial. Okay.
Look
sorry
at this
about that.
slide. This was a question that I had for us in Harlem. This tells you all of these bursies. Look at the bursies. You guys know about the ankle joint. Inversion injuries are the most common. The ligament that gets broken in an inversion injury is the anterior talofibular ligament. This is the one that most commonly tears. This is an X-ray of showing you the talus, the calcaneus. This is the navicular. This is cuboid. This is lateral cuneiform. This is just, it's all labeled. So if you want to review that, you can. There was something I wanted to, oh. Where is that question that you wanted me to answer, dude? Which one of you sent me that question? Everybody had a question about the question from class where so the question said, if the right femoral nerve is injured below the inguinal ligament, what loss of function will you have? And the loss of function you would have is from sitting to standing. You wanted me to explain why flexion of the hip is not affected. First of all, the flexion of the hip won't be affected because psoas major is not supplied by the femoral nerve. It's supplied by L1, L2, L3, the same nerve roots, but it gets its innervation in the abdomen, in the lower part of the abdomen. And iliacus gets its innervation in the pelvis. So this nerve injury happened for the femoral nerve, and it happened below the inguinal ligament. Do you guys know what I'm talking about?
Yeah.
It's slide 80.
Where are you? Slide 80. Do I have it? There we have. So, first of all, this is the key, people. The nerve injury, distal to the site of the nerve injury, you will lose function. And to stand from sitting position, stand if you do it. If you sit and you get up from a sitting position, you are definitely using tons of different muscles. But you're locking your knee, you're standing up in your quads and you're extending your quads. This guy had a knife injury just below the inguinal ligament. So anything below the inguinal ligament that the femoral nerve is supplying, which is the anterior compartment muscles, are going to be affected. To sit from a standing position, of course, you're flexing your knee, that's going to be hamstrings. Are the hamstrings working when you're standing from a sitting position? Sure. But the primary function is quads. The others do not apply here. Extend the hip is inferior gluteal nerve. Abduction of the hip is done by a bunch of different nerves. So did I explain to you what the choices are? Do you guys understand? Psoas major is supplied by L1, L2, L3, but that nerve supply is coming from, it's happening in the abdomen. Iliacus gets a nerve called nerve to iliacus. Some people consider it to be a branch of the femoral, but that's happening in the pelvis. This nerve injury is at the inguinal ligament. So anything below the inguinal ligament would be affected, and that would be the quads, and quads are what make you stand. I'm done. I can't speak anymore. I hope this helped.
Yes, it did. Thank you so much.
Okay.
Yes, thank you.
Thank you.
All right. Just
Thank you, Dr. Rich.
just do me a favor. If you have any questions before the end of this week, send me questions. Email it to me and I'll answer them. Okay.
Thank you.
Bye.
Thank you.
Thank you.
Thank you.